Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by Jonathan Brewer, Jason Lesnick, Samuel Rouleau, Patel, Millie Casse, and Clay Smith. Okay, let's get straight into the first article, which was titled, Does Cardiac Standstill on Early Focused Transthoracic Echocardiography Predict Absence of Return of Spontaneous Circulation in Cardiac Arrest? A Systematic Review and Meta-Analysis. Now, there are a whole bunch of things that we have during an arrest that we'd hope would be helpful for predicting the outcome of our patient. What is the prognosis? How are they going to end up? We'd love to have things that go, oh, okay, this is the case, great, let's just call it off. That's fine. If this is the case, then it's just there's no hope, and it makes it straightforward for us because we don't want to do things that are futile, obviously. One of the things we hope would do this would be cardiac standstill on your POCUS assessment. The heart isn't even trying to contract. Is that enough to say, hey, you know what, let's call it? Or is that just not going to be good enough? So this was a systematic review and meta-analysis that tried to put together the data to decide how good is that really? How reliable is that really? They analyzed 24 studies, about 3,600 patients for this, and they were able to put together the sensitivity and specificity of cardiac standstill on POCUS to predict the outcome of absence of ROSC. And so the sensitivity was about 86% and the specificity only 79%. That gives a positive likelihood ratio of 2.69 and a negative likelihood ratio of 0.22. After subgroup analysis as to whether or not this was a medical or traumatic arrest, it didn't seem to really make a difference. Furthermore, just like all things with POCUS, we usually assume that the better the sonographer, the more reliable the exam. However, in this case, sonographer training did not significantly impact the diagnostic performance. It can be a little bit tricky to say, hey, is that true cardiac standstill or not? But apparently it doesn't seem to matter how experienced you are. And so anybody can recognize a heart that's just not moving. So that means, unfortunately, that cardiac standstill is not going to be your perfect prognostic marker. The specificity is way far away from 100%. So if you see cardiac standstill during your arrest, this is not the end all of being able to call it. It's unfortunately not going to be that good. You still have to incorporate other things in your assessment. What's the end tidal CO2? What's the clinical context? How long have they been down? How old is this patient? What are their comorbidities? These are other things you have to think about. You can't just write it off to cardiac standstill, unfortunately. In a spoonful, cardiac standstill on TTE during arrest is indeed a poor prognostic marker, but it's not the end of the line and certainly lacks enough accuracy in predicting the absence of ROSC to justify termination solely based on this. And then the second article, titled The Diagnostic Yield of Computed Tomography and Point of Care Ultrasound After In-Hospital Cardiac Arrest, out of the journal Chest. Okay, so we've had a bunch of articles in the past. We've even covered some on the journal feed that look at, hey, you know what? The patient had an out-of-hospital cardiac arrest. Just pan scan that sucker, and you might actually find out what happened. Or at the very least, you're going to identify injuries that, could be important that were the result of your chest compressions. What we have less data about is how useful are scans, and in this case, POCUS, for identifying what's happening, changing your management in patients who have an in-hospital cardiac arrest. This was a retrospective observational cohort study that examined the diagnostic yield and clinical management changes as a result, as I said, of CT and POCUS out of in-hospital cardiac arrest after they indeed got ROSC for at least 20 minutes. They were able to find 345 patients over a 2-year span who had a CT or POCUS done within 48 hours of their ROSC. And only 48% of patients actually got a CT within 2 days, which is a lot less than I would have thought. And most of those CT scans were CTs of the head, 89%, which is, not that I, fault people for getting a CT of the head, but it's not usually going to tell you why the patient arrested, so I'm surprised that it was mostly CTs of the head. Maybe it's because a lot of these patients were not waking up very well, and you already had some idea why they would have arrested because they were in the hospital already, so you probably know some things about them. And 25% of the CT heads overall were positive, so you're seeing some results quite a bit of the time. That's impressive. And for these CTs, it changed management 73% of the time, which is pretty huge for these CT heads. Overall, CT found, new abnormalities in 65% of scans, and about 66% of the time it changed management. Now, I wish people would be a little bit more specific about clinically important management changes. Not everything necessarily needs to be treated, and we likely overconsult. Like if you get a consult, that's going to be considered management change. But if the consultant comes by and says, hey, don't do anything about this, then I'm not going to care as much per se. But I understand why they would do this as this, because otherwise you get quite subjective as outcomes. Then I'd be criticizing that, and then we're not getting anywhere. As for POCUS, 57% of the patients had a positive POCUS exam with change of management in about 25 to 30% of patients, which also is huge, and POCUS, easy to do, something you should probably be doing on any patient that just arrested. If you're only looking at the results that were thought to be the reason for the arrest, then 20% of CT scan patients had that reason. And again, just about 20% of the POCUS group also found that on POCUS. So you're actually getting about a fifth of patients, and you're identifying why they had an arrest just by doing these scans. So I think this really justifies, at the very least, POCUSing your patients. And you should be quite liberal with your CT scans as well. CTs of the chest had the highest rate of finding new findings. Not that surprising, they arrested, you're probably going to find rib fractures, things like that, but also a great diagnostic yield for seeing things that are actually important otherwise for, patient management. Overall, though, this is a retrospective study, and this kind of thing is never going to really answer questions about this. It's just going to be sort of justification for practicing in this way. This is just proof of practice that is published. Having a retrospective study like this, there's so much subjective bias into who gets scanned and for why that you should not make this a reason that you should scan. Overall, though, these results do fit with the AHA guidelines on out-of-hospital cardiac arrest, which is that you should be pretty liberal with your scanning because, it can be quite helpful in these patient populations. These are sick people. They just died. So if the scan is what you think you need, get the scan. In a spoonful, post-arrest CTs and POCUS, even if you do them pretty blindly, would probably be a legitimate strategy to aid in finding the cause of arrest. You have a pretty good diagnostic yield off of these scans, whatever those scans may be, as appropriate for your patient. Okay, that's all the articles from this week. Let's do a quick wrap up of what we talked about. From the first article, cardiac standstill during a cardiac arrest is a poor prognostic marker, but it's just not good enough to use as a complete and reliable white flag. So you've got to look at everything else, the clinical context as well, because it's just not going to be a good enough sign that this is time to give up on that arrest. From the second article, scanning recently dead people, those who just got ROSC within 48 hours, while CTs and POCUS frequently found problems and important ones, so you should be scanning pretty liberally. Now, if you were hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were those articles that you missed? Well, we talked about what is the best way to examine your patients and determine if they have volume overload. Then we talked about cold water immersion and whether or not we should do that on the ambulance. And then finally, is apixaban going to measure up to rivaroxaban? Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.